Minimal or measurable residual disease has really become a major, if not the main, biomarker in myeloma, and particularly probably the main one when it comes to assess a treatment response. It has been very elegantly shown that MRD really matters more than any other more traditional assessment of response, such as paraprotein levels or marrow plasma cell percentages assessed by morphology. So it's not a big stretch to think that something that captures so well treatment response will have a major impact on how patients do a long time. And I think it's very intuitive in oncology in general, certainly in myeloma, that one would adapt therapy according to the needs of the patient. In other words, perhaps treat less intensively a patient who has an exquisitely good response, and being more intensive on your therapy on patients who don't respond very well. So I think the premise of MRD is pretty intuitive. And I think data supports that. Clearly is a very strong prognosticator of progression-free survival and overall survival, but also several recent landmark trials have really demonstrated that at a given time point, patients who have become MRD negative tend to fare far better than patients who are MRD positive. So I think there are several circumstances where that is very appropriate. I think one that I would often highlight are patients who have completed proper induction therapy, have completed autologous transplant, and then we have to make a decision whether or not to use consolidation, whether or not to use maintenance, and what to do and what to use. And I think data is pretty clear that patients who are MRD positive after transplant don't fare well long time. So I think in that setting is very appropriate to, for example, introduce a new class of agent that is active in that disease that the patient might not yet be exposed to. And I think a good example is CD38 monoclonal antibody. And that's something that is probably more important even on patients who have biological high risk. Another perhaps more controversial point is it comes to the use of maintenance therapy. Although maintenance has really been a fixture in myeloma therapy for now over a decade, we know it doesn't benefit everybody equally. And I think with the improvements in upfront therapy, particularly with the adoption of quadruplets, it has become clear certainly from the Cassiopeia trial in a smaller scale on the master trial, that patients who are not ultra high risk, who achieve and sustain MRD negativity for at least a year, they do exquisitely well even in absence of maintenance therapy. So I think there's very little to conquer in terms of reduction of progression by introducing maintenance therapy. It will be very appropriate to omit it. Another point I think that comes very frequently on discussions with patients are a patient who has been on maintenance therapy with lenalidomide for a number of years, and the discussion comes up of whether or not to cease therapy since we don't know the optimal duration of it. And I think we learned recently from the Myeloma 11 trial done in the UK that the impact of maintenance is really modulated by the duration of therapy with a decreasing impact over time, and is strongly modulated by the MRD status at the onset of maintenance. So for those patients who are MRD negative, who have been on maintenance for 1 or 2 years, I think it would be very appropriate to omit further maintenance, spare the patient from the toxicity, and likely have a more responsive disease if and when the progression does happen.